Hello everyone, this is Kayla Garcia Luquis, and welcome to my presentation about assistive technology interventions for occupational therapists in low vision rehab. So throughout this presentation, we will be covering low vision's definition, etiology, and epidemiology. We're also going to talk about what is low vision rehab, the key players in the multidisciplinary team, the role they played in the service delivery process, and the professional ethics they must abide by. And finally, we will cover some of the AT interventions most commonly used by OTs specializing in low vision and the potential factors that may lead to equipment or technology abandonment. Low vision is defined as a permanent vision loss from a condition or a disease that cannot be corrected by eyeglasses or medical intervention and that interferes with the person's ADLs. A person is considered to have low vision when their visual acuity is 20/70 or poorer. According to the National Institute of Health, about 57 million people in the United States are living with some type of disability. Among these people, a total of 14 million are believed to have a visual impairment, including those with conditions that can and cannot be corrected. It is important to note that these numbers do not include people who are legally blind. In America, there are about 1.3 million people who are legally blind and 3 million with low vision. Together, they account for nearly 4.2 million Americans living with vision loss. There are many different causes of low vision, including neurological factors, as well as medical, congenital, or acquired disorders. But for this presentation, we're going to focus on the leading causes of low vision in the adult population. They are macular degeneration, diabetic retinopathy, glaucoma, and unoperated cataract. Macular degeneration affects the central vision and the ability to see fine details. So the person will experience wavy or blurred vision, and if the condition continues to worsen, the central vision may be completely lost. On contrast, glaucoma usually affects side or peripheral vision. People seem to be looking through a tunnel, and over time, the central vision may decrease until no vision remains. Cataract is a clouding of the lens in the eye. Some of the symptoms include blurry or double vision, and colors may appear faded. The person may also experience sensitivity to glare and/or night blindness. Diabetic retinopathy is the most serious vision complication of chronic diabetes. People with DR may experience decreased, fluctuating, or distorted vision. They may also experience issues with focusing, blurry or double vision, loss of color vision and contrast, and eye pain or pressure in the eye. Some of the general risk factors in low vision include: number one, age. According to the WHO, 81% of all people with visual impairment are aged 50 years and above. Race and ethnicity is another factor. So based on the statistics, overall, there is a higher prevalence of low vision in whites. But if we look at each of the specific causes of low vision, we will find that, for example, the prevalence of macular degeneration is higher in whites, and among Hispanics, glaucoma has a higher prevalence. Health-related issues, including comorbidities like diabetes, can also be a contributing risk factor to low vision. Some of the functional implications in low vision include the person's ability to read and write, access to printed or electronic information, access and participation in leisure and social activities, performance of activities of daily living, and instrumental activities of daily living such as cooking, sewing, and driving, and the ability to maintain their independence and quality of life. So what can we do to help this population? People who experience impairments of visual function may benefit from low vision rehab. Low vision rehab is a treatment modality delivered by a team of eye care or rehab professionals with the main goal of improving the person's quality of life. Because low vision is irreversible, the focus of low vision rehab is on helping the client use their residual vision as efficiently as possible through the use of compensatory strategies and assisted devices. The multidisciplinary team in low vision rehab come from a wide range of educational and training backgrounds with various specialties. An ophthalmologist is a physician or medical doctor who specializes in the medical and surgical care of the visual system and in the prevention of eye disease. Typically, their primary role is to evaluate and identify the patient's current medical status and provide a clinical diagnosis. He or she may also refer the patient to other professionals for rehab when surgical options cannot restore the vision loss. Although the low vision assessment is usually conducted by an ophthalmologist, it could also be carried out by an optometrist, which is a healthcare provider who specializes in the examination, diagnosis, treatment, and management of disease of the visual system. They also provide treatment modalities that include the use of eyeglasses and contact lenses. Occupational therapists try to help people be as independent as possible in what they want or need to do. The focus is on the person's ability to engage in their activities of daily living. They also address issues involving sensory and perceptual motor skills. OTs may also perform an assessment of the person's home, workplace, or school environment. The role of the vision rehab therapist is to provide instruction and guidance in independent living skills. They also teach Braille and the use of assistive devices. The orientation and mobility specialist provides instruction in travel skills. Although these two disciplines are not licensed professionals, they are certified as vision rehab therapists or orientation and mobility specialists. The low vision therapists teach people how to use the special optical devices prescribed by the primary care provider. A case manager can be a social worker or a nurse case manager, and their primary role is to coordinate the care of the patient. They also act as a contact for the multidisciplinary team and the patient and family. The mental health specialist, usually a psychologist or psychiatrist, typically addresses the psychological implications associated with vision loss. Because medical knowledge grows continually, it is imperative that professionals working in low vision rehab keep themselves up to date with the latest information and technological advances. This can be done through professional development such as continuing education and in services. Practitioners should always refer to their professional practice standards designed to promote consistent and efficient good practice. In the particular case of OTs, there are different accreditation agencies to explore certification in low vision rehab. One is the Specialty Certification in Low Vision, or SCLV, offered through the American OT Association. The Certified Low Vision Therapist CLVT, granted through the Academy for Certification of Vision Rehab and Education Professionals, and RESNA's ATP certification, specifically designed to demonstrate a basic level of competence for those providing services in different areas of AT. OTs also need to understand the importance of cultural competence. Therapists who can acknowledge and appreciate unfamiliar cultural worlds is much more likely to be effective in treating a wide variety of patients. And finally, the importance of implementing evidence-based practice in the care of patients. When we use evidence-based interventions delivered with a person-centered approach, we're basically applying relevant research findings to guide our clinical practice for increasing clinical effectiveness. Because low vision rehab uses compensatory strategies and assisted devices, AT has become critical to the success of these services. AT is defined as services, devices, strategies, and practices that are conceived and applied to increase, maintain, or improve functional capabilities of individuals with disabilities. OTs have become especially instrumental in developing and providing services in both low vision rehab and assistive technology. Based on their educational background and clinical experience, OTs have the knowledge and skills to assess clients and provide assistive technology devices and services to support people with low vision and to minimize barriers to function. Because low vision rehab and AT easily merge, it is possible for a wide range of interventions to be applied to improve the individual's functional outcomes. AT devices may serve similar or quite different purposes in people's lives. These technologies can range from no to low and high technology. In low vision rehab, ATs can be further divided into four main categories. These are the services, non-optical devices, optical devices, and electronic systems. The main goal of no-tech AT is to provide education and treatment to the patient. These interventions may include environmental modifications, such as optimizing lighting, the use of contrasts. For example, in the picture, it would be easier for someone with low vision to identify milk in a black cup and coffee in a white cup. Patients may also benefit from minimizing clutter for fall prevention. For community mobility, people who wish to continue driving should have their driving skills evaluated. The OT may also provide recommendations for independent traveling, learning how to use public transportation, and negotiating complex environments. Recommendations in the area of ergonomics may include positioning of the computer screen in front of the person at a comfortable height and distance. Low-tech devices are usually simple in design, inexpensive, and require little or no training for effective use. Many of these items may be employed by using simple non-optical solutions or optical aids. Some examples of low-tech include magnifiers for reading and books or documents with large print. To assist with writing, the use of templates can also be beneficial. Mid-tech devices are described as those that are battery operated and are considered simple electronic devices. Examples of mid-tech solutions include the use of telephones, remote control, and clocks with enlarged numbers and contrast. High-tech devices are typically expensive and more complex to use. Some examples are video magnifiers such as CCTV, optical character recognition, computer systems like the hardware such as the adapted keyboard, screen magnification, and voice output readers to assist with computer use, mobile devices with accessibility features for low vision, as well as current iOS and Android applications like the ebook reader. Equipment abandonment is sadly very common among people with disabilities who relied on AT. Three main factors associated with abandonment are: number one, device-related; number two, environmental-related, including social stigma and lack of acceptance; and number three, service-related, or lack of consumer involvement in device selection or access to training. So what can we do to increase equipment utilization and minimize the likelihood of abandonment? Because issues associated with AT abandonment can be multiple and extremely complex, special attention should be placed on the evaluation, selection, and recommendation of AT by the OT. The selection of the ATD should be matched to the person. In addition, the OT needs to consider the activity, the physical qualities of the person's living environment, the person's sociocultural background, as well as the person's age at which disability occurs. And finally, the need for follow-up is crucial and highlights the importance of evaluating the outcomes of the AT interventions to determine their effectiveness. Because the provision of low vision rehab and assistive technology is an ongoing process, follow-up appointments are recommended to continue addressing the user's changing needs.